Thank you, Hira. Thank you, John, for inviting me. So I'm going to talk about neurotrauma care in the LMIC's perspective, and I'm going to try and explain what you already know, I suppose, the difference between the developed countries and the lower and middle income countries, really. This is my hospital. Um, we know that 74% of surgeries for traumatic brain injuries are needed in lower and middle income countries. These are the number of surgeries needed, not the number of surgeries done. So there's a big gap of surgeries required in the lower and middle income countries. And that goes again also for traumatic spine injuries. More than 89% of the traumatic spine injuries occur and the surgeries are required are in the lower and middle income countries. So there's a huge number, and we know that there's a big gap of the number of neurosurgeons required in the world, and most of them are from the lower and middle income countries. And I think the numbers are more than 20,000 neurosurgeons required, really. And this is the reason because of the bad traffic. As you know, accidents, people are not following traffic rules. They're not caring about themselves. Although the rules are there everywhere for everybody to follow, but people do not follow them. And this is a slide which everybody is seeing all the time, everywhere. I think it's a competition to see the numbers increasing on the motorbike, really. We did some, in our neurotrauma registry, we looked at the patients coming to us with head trauma, and we saw that in majority of the patients on motorbike accidents, they had no helmets. The 30% unknown, I am sure, would also be the ones who are not wearing helmets. Also, then if you look at the seat belt, then again, majority of the patients coming in with road traffic accidents were not wearing seat belts in our setup. And of course, then the terrorist incidents happening all over the world in different areas, recently in Sri Lanka, unfortunately, also. So we know that if we strengthen the trauma systems, including the pre-hospital care and transport and initial care in the emergency departments, it will make a very big difference to the number of patients who are saved, really, and who would do better later on. So when we look at what is required and when we look at what is different between us and the developed countries, most important is pre-hospital care, there is the ER care, intensive care, rehabilitation. And then the most important things are the neurotrauma registry, neurotrauma guidelines, as was just suggested by our friend from Nigeria. And the foremost important thing is the prevention of neurotrauma. When we look at this small study which we did in 4 countries from Pakistan, from India, and from Surabaya in Indonesia and Pasar, we found that majority of the patients really who had an accident, they were provided emergency treatment by the local bystanders and not by the ambulance service. There are very few ambulance services, they're not available. And if there are any ambulance available, they do not have any trained paramedics or oxygen or suction or any facilities in the ambulance. And if you look at this slide, when we looked at in these countries, a majority came into the hospital unaccompanied by a nurse or doctor or a paramedic. So very important to develop pre-hospital care, and I think in most of the lower and middle income countries, this would be the foremost thing, what we would be doing, to develop ambulances, train personnel, so that the patients can be treated at the site of accident and then can be transferred safely to the hospital where they are required to go. And when they arrive into the hospital, that they have proper trauma beds and trauma care. Intensive care management doesn't have to be ICP monitoring. Of course, it is something which needs to be done, but it is not something that if you don't have ICP monitoring at the end of the world. No, you can treat, you can manage head injuries in intensive care. Protecting the airway is very important. And one way of protecting the airway, if you cannot intubate and ventilate, is doing a tracheostomy. That makes a very big difference by helping the patients improve their oxygenation and giving oxygen on time really. Of course, if you ventilate the patient, do ICP monitoring, do all the parameters, it's going to make even better difference. After doing all that, rehabilitation is something which is not available in most of the lower and middle income countries. In fact, if you look at studies where patients were treated for craniotomies, decompressive craniotomies in low and middle income countries, and in developed countries like a study from India and United States, the initial outcome score was the same, but 6 months outcome score was big difference because the patients in the United States were getting rehabilitation, where in India they were not getting rehabilitation, and the mortality rate suddenly increased tremendously. So it's very important. And when we look at this study again from these 4 countries, we found that majority of the patients are being discharged to their families. And one way of looking at it, what we found was to train the family members in giving physiotherapy, tracheostomy care, limb care, DVT care, catheter care, and nasogastric tube feeding, etc., to the family members. And that we have found is helpful. And if it is done in a proper fashion, in a structured fashion. Data systems are not available. We know some people use police data or some combined databases. The reason, as we say, that the 90% of trauma occurs in LMICs, but 90% of papers on trauma come out of developed countries is because there is no trauma registry. And I think this global neurotrauma outcome study is a very big step towards inculcating into our minds that we must have a trauma registry, neurotrauma registry, and also teaching us how to make a neurotrauma registry. And I think moving forwards and developing a international neurotrauma registry would be very good. We in our hospital have our own neurotrauma registry. This is a web-based online registry, and you can have so many parameters. And it shows us here that the time from injury to presentation is greater than 24 hours in majority of the patients. And so we know that, first of all, that the neurosurgeons are not available in remote areas. All the neurosurgeons are concentrated in the urban population. The roads are very bad, and the pre-hospital care is not good, and most of the people are being transported in their own vehicles there. And of course, this is the TBI diagnosis of different patterns. And you can see that the type of severe injuries and moderate injuries. So I think it's very important to develop a neurotrauma registry. Guidelines were mentioned. I think setting the minimal standards of care from the accident site to the hospital and to rehab are very important. If we say that we do not have high-tech facilities available and so we cannot have proper guidelines, no. I think it's important to develop guidelines, and that is why the Neurotrauma Committee has tasked a group to develop multi-layered guidelines so that starting from lower level but reaching to the gold standard of guidelines. Every country and neurosurgeons must strive to develop guidelines for the peripheral hospitals, the referring hospitals, and for their own neurosurgeons for pre-hospital care, ER care, and in ICU and in theater. So it's, I think, something very important. This is a thing written in Urdu. This is it's something which is given to the patient's relatives when the patient is going home to ensure that if there is any problems for the patient, they're all written down. These are some guidelines for the patient's relatives that if the patient is vomiting or has got headache or has fits, that they must bring them back to the hospital. I think This is something which can be done by everybody, just a piece of paper given to the patient's relatives. But the most important thing is prevention. I think we know very well that most of the injuries, head injuries, can be prevented, and we teach people here by doing regular walks in our neurosurgical society meetings, by having conferences and using students to develop posters. And in one of our colleges, a non-medical college, home economics college, they have it in the curriculum to go and teach students in schools, school children, about the prevention of neurotrauma. And I think, again, something which the lower and middle income country neurosurgeons must look at and spend time on. And you must get in touch maybe with Think First International, which is the International Injury Prevention Foundation, which works a lot on prevention. And the Neurotrauma Committee of the WFNS has partnered with Think First International on this thing to do prevention of head injuries. And this is something which I must show you, this collaboration with WHO and many organizations on the Vietnam's mandatory motorcycle helmet law. You would be amazed at the number of people who survived, who survived the following day when the helmets were made mandatory. And the helmets were made cheap, and they were porous, so that the concept of this thing of having in the heat you cannot wear helmets, that was taken away as well. So out of the box thinking, and I think if you go to Hanoi now, you'll find that everybody is wearing helmets there. We have been working with Key Park, the Harvard Group School of Public Health, on developing comprehensive recommendations for management of brain and spine injuries. And these are for the public, for the government sector. And we are going to present them on 15th November 2019 in Peshawar, along with the ICRAN, which unfortunately we had to postpone from March. And we would love for all of you to come here. And the idea is that 80% of the world has access to essential neurosurgical care by 2030, and 80% of the world is within 4 hours of neurosurgical center by 2030. And very important that 90% of LMICs with national neurotrauma plans in place by 2021. We have piggybacked it on the national vision for surgical care in Pakistan, which is going to be the vision for 2025. And this is the on the National Surgical Obstetric and Aesthetic Plan, which the WHO has proposed. So all of you must look at this, the lower and middle income countries. And the plan is that we should develop the Peshawar recommendations in November and go forward. And in 2021, we should have done more when we go to Colombia. And this is the timeline. Another thing which we are working on is mass casualty centers to integrate for natural and unnatural disasters, and between collaboration between developed and developing countries, for health delivery, for medical education, for medical research, and poverty reduction. Our center, Northwest General Hospital, now is a WFNS collaborative center for neurotrauma for 3 months, and anybody interested, they can come here for 3 months for neurotrauma training, and we provide free stay, accommodation, and food here. And I would like to welcome you all again, once again, to the ICRAN from the 14th to 17th November, and we still have some scholarships which we can give to young neurosurgeons coming from lower and middle income countries. Thank you very much.
Thank you so much, Professor Tariq Khan.
Okay.
Thank you. So do we have any comments, questions from the panel?
Yes,
Anyone?
yes.
Yes.
Good morning, Professor Tariq. I'm so glad to meet you again on the panel. I remember, I hope it is in August or September, when you maybe done here a webinar about hysternostomy. And you show me well how to dissect gently carotid around optic nerves. I'm so glad to meet you again, and thank you for your brilliant presentation. It is so clear. And now the problem we have, it is about severe injury of brain. And I am on one work, prospective one work in my department about traumatic brain injury severe, and we don't have ICP monitoring, but we done Doppler transcranial to have correlation about clinical and imaging CT scan before take decision about management. And now I am really convinced that only cranectomy decompressive not just sufficient. We have to go both about cranectomy decompressive and cysternostomy. And I read one paper of you. I think you when you done your last presentation webinar, and we have to move together about this recommendation, and it will be great benefit about our patient. And I want to thank you very much, and say welcome to all guys who come in this panel today. Thank you, Professor Tariq.
Thank you very much. Thank you. And I look forward to you joining us in November in Peshawar and giving a presentation on your experiences on neurotrauma and management.